Hello, everyone. Thank you so much for joining us today. We're not quite to the top of the hour yet, so I'm going to allow some time for everyone to flood in from the lobby. And you can listen to us as we try to decipher which side we're looking at in the camera here. So, well, not me. I'm not sharing my camera today, but we're having fun conversations. I always feel like we need some on hold music or something here. Fill the silence, right? Well, guess what? It is 2 o'clock, so I will stop talking and I will kick us off. Welcome to the Rural Health Executive Educational Series. I am Cody Smith, Partnership Manager with NRHA Service Corporation, and I will not be serving as your moderator today. Actually, Karsten will be doing that for us. Before we dive in, though, please note there is a short survey at the end of the session, and your feedback is invaluable in helping us to refine and tailor our future series to best serve your needs. So I'd really appreciate it if you could take a few minutes and fill that out. Few housekeeping items. All attendees are muted during the session. This does help us just to avoid some background noise, but don't hesitate to put those questions that you have for our presenters at any time into the control panel of the question section, and we'll make sure that we address those. Also, this is being recorded and you will receive an email with a link to the recording tomorrow. Please feel free to share that link with anyone who you feel needs to see this information or can benefit from what we're sharing today. And today we do have the privilege of hearing from Dr. Corey Scurlock, Equum Medical Founder and CEO, Donna McHale, Huron Consulting Group Principal, and Jessica Duke, Huron Consulting Group Director, as they present Building Resilient Rural Healthcare, Strategic Solutions for Financial Stability and Enhanced Care Delivery. Before we begin, I would like to extend my sincere thanks to our dedicated partners, Equum Medical and Huron Consulting Group. We at NRHA are so grateful for your continued support and the industry expertise, which allows us to host conferences, educational presentations like this, and other events dedicated to improving rural health care. Your support is crucial to our mission of advancing rural health initiatives. Okay, without further ado, I'm going to turn it over to Karsten, and he will kick us off today.
Cody, thank you, and good afternoon, everyone. This intimate fireside chat is really built from a long-term relationship between Donna, Jessica, myself, and the companies we represent, which are Huron and Equum. We're grateful to the relationship with NRHA because, as we know, for rural health to truly transform and become sustainable, it requires partnerships, and it requires collaboration, and it requires open, courageous conversations that allow us to be vulnerable and share what we know. And if we take what we know and combine it, we can actually do better and we can help more people. That was the genesis behind building resilient rural healthcare, strategic solutions for financial stability, enhanced care delivery, because when we visited with different administrators and health systems or hospital partners at the Kansas City meeting across the country, over the past year, what we reflected on was that bringing these stories together would allow each of you to hear a different perspective. And oftentimes, as we meet at our local hospitals and have conversations about financial stability, enhanced care delivery, challenges that surround workforce or innovation such as telehealth and technology, those conversations are with an N of one, with a market level of your local market. And truly, this is what's special about today's section, is hearing those perspectives at scale. And as Cody mentioned, really, truly wonderful to have Donna and Jessica on, and myself speaking with Dr. Scurlock in advance of this, really understanding his personal journey, which I'll share today, which makes care in rural America personal. And really, I think everybody has a personal story, and we're going to hear Donna's personal story and Jessica's personal story as well. So as we kick it off and we talk about how we want to spend this time together, we wanted to be very intentional that you can leave this conversation with truly actionable insights about how to assess and understand ways that workforce and telehealth and technology solutions can be applied to your local hospital to generate meaningful outcomes. And we're going to do that also with case studies that we share here, but also hopefully after the session, we can engage and talk about those specific examples and give you more specific calculators and ways that help you apply what we talk about today to your local hospital. So with that, we've divided the conversation today into a background by Donna and Jess, and I'm going to hand it over to them here. Following their session, I'm going to share a little bit about what we see through the lens of a founder CEO like Dr. Scurlock, as well as how we can help hospitals through technology, but also through workforce innovation. So let me turn it over to Donna. And Donna, of course, as we do this chat, let me know and I'll move us forward.
Great, thank you, Karsten. Next. Hi, I'm Donna McHale, and I'm a principal in Huron's healthcare technology practice. I live in Chicago, and I have over 40 years of healthcare IT experience. And just wanted to share with you that one of my passions is this camp that I lead. This summer was my 37th year leading a program at Camp One Step, which is a camp for children with cancer. So it's important for me to work with that program, and it focuses me every single day. So now next, Jess, we'll have you introduce yourself.
Great. Thanks, Donna. So my name is Jessica Duke. I have over 20 plus years in the healthcare field. My background's in nursing and in digital health. I reside in Beaufort, South Carolina. Have practiced in the rural health space of Beaufort and in South Carolina, taking the healthcare and telehealth space out into the rural regions of South Carolina. I live on the coastal part. As you can see here in my pictures, I spend a lot of time in the Beaufort River, and I love spending time with my children. And I'm going to call out my furry friends first. I have 2 golden retrievers, and then my next 2 children, which are not my favorite at the moment, but Lily and Will here as well. I recently got engaged and plan on getting married this December. So as I like to talk a lot about digital health and telehealth, we're going to move into the next slide, because you can't talk about telehealth and digital health, and particularly in the rural space, without talking about the financial components of it. So when we think about brainstorming out what are some of the financial drivers in this arena of rural health, certainly workforce strategies is one of the pieces of this. When we talk to a lot of our rural clients, they're talking about recruiting and retaining healthcare providers. And this has been a chronic challenge within this space. And when we talk to them, a lot of the contributing factors that they're leaning into is around income. How do they compete against the larger institutions? But then also lifestyle is a challenge. You know, many people don't want to live within a rural space, or they don't feel like they can live into that rural area. And then fewer opportunities for advancement, or maybe they don't feel like there's good opportunities for training and education in rural organizations. Another challenge they face is around reimbursement disparities. Many or majority of the rural hospital revenue is coming from government payers, but what we're finding is those payers are not reimbursing as well as they would at a larger institution, and sometimes it's even like half the cost of providing the services. And even commercial payers are a challenge. What we're finding is that they're driving those patients outside of the rural institutions because they're seeking in-network care. Another financial driver we're finding is around that provider shortage. Only 10% of physicians are practicing in the rural areas. One of the things that we find when we do our assessments is that there's a huge deficit of behavioral health providers. And one of the statistics I think is really interesting is around that psychiatric nurse practitioner. 81% of rural communities lack psychiatric nurse practitioners. Low patient volumes is another challenge that they're meeting, Because these populations have low density, they don't have a high patient volumes. But a lot of the communities that we're serving, their populations may only be 5,000, 6,000. But that 5,000 or 6,000 people may be underinsured or uninsured. They're geographically isolated, but they also have limited access to transportation to even access the services that these critical access hospitals are providing. Another challenge that they're meeting is the high operating cost. This cost could be associated with medical supplies, but also the transportation of that medical supplies, and then the utilities to keep the lights on within the organization. There's several institutions we've met with recently that are having the financial strain of aging facilities or building new facilities. They have the goal of building this new critical access hospital close to them, or infrastructure rebuilds, hardware updates, and just the high cost of the staff alone. So it's creating this financial cycle, and how do they meet the demands of that financial cycle? One of the areas that I really want to hone in on here is that workforce shortage. So if we move to the next slide, I want to look and talk about a little bit more around the nursing body. So Karsten, if we can move to the next.
Yep.
So if we think about the current environment around the nursing body and how and what statistics are out there to kind of drive us to think and plan and do differently, we want to think about the turnover around the bedside nurse. In 2023, it was over $52,000 that it cost around the turnover of a bedside nurse. There was an increase of 13.5% associated to this. So what else can we think about here? Well, there's anticipation that a 6% growth in nursing workforce is expected. And that is causing us to think about 203,000 RN openings per year that is predicted until 2031. What else is correlated to this? Well, 93% of healthcare workers are reported stress. 86% are reporting anxiety, but yet only 13% say that they are receiving behavioral health services. Additionally, we're hearing that there's a rise in contract labor. We all know this coming out of COVID, and that is 37% increase of labor expenses per patient. So how are we supporting this new trend and this new demand of nursing at the bedside? Well, you'd think that U.S. nursing schools would be able to produce additional nursing, but they can't. They're strained as well. 78,000 qualified applicants were turned away because they don't have sufficient faculty and resources. So there's huge strain on the workforce. So where do we go from here? I'm going to leave that to Donna to explain more steps.
Thank you, Jessica.
You're welcome.
As we move to the next slide, as organizations are starting their journey to think and do differently, they're reevaluating their vision and their strategy with the understanding that tracking workforce shortages is multifaceted. And in that, there's no single initiative that will solve the healthcare's current workforce crisis. Your strategy has got to include a robust and diverse portfolio. And one size doesn't fit all. Each organization's journey will be very different based on their environment, their challenges, and their leaders. The digital strategy is a journey, and the leaders should prepare for a multi-phased effort to build their workforce of the future. And there's never a good time. Putting talent and digital strategy investments on hold to weather the immediate storm puts your organization at risk. And top of license practice is truly a positive disruptor. Leveraging the unique skill sets of nurses is an absolute necessity so that they can tackle organizational goals. So now let's talk a little bit more about that vision and strategy as we move to the next slide. Organizations are being innovative in their thinking and are advocating for different during these transformational challenges. They're bringing interdisciplinary teams together so that they can design work beyond the traditional vertically focused resource allocation. These efforts need to focus on developing care and staffing models so that they position the caregivers to practice at the top of their license. Organizations are taking a minute to ask themselves, what care models have worked in the past? What innovation should we implement to advance the top of license practice for nurses? And then when we look at the patient-centered care clinical nurse leader model, here's where the care delivery is organized around the patient's needs across the care continuum. Highly skilled nurses are managing an assigned population, and they're driving the outcomes, as well as managing the patient's care coordination, progression, and task and care delegation. When we look at that novice to practitioner nurse model, here's where the nurses who are skilled in critical thinking and delegation are managing some of the new nurse graduates, and they're helping them develop those same skills. And with the teacher practitioner model, organizations are looking at what will their care models, their education models shift to in order to prepare the caregivers for the new care models. And here, the advanced practitioner performs in a hybrid role, for clinical and professional development. So as we move to the next page, we'll look at how technology plays here. So the organizations are exploring how technology can provide some relief for these transformational challenges. We've seen many organizations start to look at their virtual care models. And so they're questioning if their leaders are prepared to develop and lead a diverse workforce using emerging technologies. And then they're looking at virtual and remote staffing and different models to be very different outcomes for them. And so some of the things for virtual caregivers they're looking at are to provide the preceptor guidance, rounding, completing some of the assessments like admission and discharge. And then we start to look at intelligent automation. So as we noticed in some studies, intelligent automation is going to become a very key component in every industry and job type. So organizations are exploring how to transform their care spaces to actively monitor things like patients, enabling the flows, and integrating with technology. They're also looking at smart care spaces, such as the ED, patient room, and then the patient entry into the rooms. And some of the smart care rooms are being integrated with technology so that they can take care of urgent and non-urgent patient care requests, the patient care board, virtual care and ambient monitoring. And then we look at digital transformation. So at this point, organizations are asking themselves, if they can innovate and pursue the bold moves that it's going to take to accelerate and redesign and enhance long-term sustainability, as well as what do they need to maximize automation capabilities to reduce the burden on the employees. So Carson, with that, I'm going to turn it over to you.
Jess and Donna, thank you. I've taken some notes, and for our audience here, thank you for listening in. As you have questions, I want to encourage you to add them to the questions chat box, which we'll monitor and get to as we move through this session. With that introduction, we see, and at least with the notes I've taken, Donna and Jess, what I get is a structure. It's a blueprint for how organizationally to make sure that I'm asking the right questions, making sure that I'm collecting the right inputs, and then having the right conversations and bringing them the right partners to be able to change that paradigm. What I will now switch to is a conversation on resiliency and patient care delivery. This really starts with the story of who we are, right, and how we meet. Yesterday, just to be transparent, I was at the Maryland Rural Health Association meeting with Dr. Scurlock, and we got to hear stories across the state of Maryland about how workforce challenges were impacting transfers of patients and, of course, access to specialists. The journey of Equum is exactly that journey, which started with the story of Dr. Scurlock, advancing through a formative upbringing in rural Texas, and then pursuing a career in healthcare and medicine, and realizing that the ability to scale the impact of his background could only come through telehealth technology and being able to increase one's impact from, delivering care in person to delivering care at scale at a distance. And so Equum Medical was founded in 2011. Since that time, we've grown and we spent quite a bit of time across the country. This year alone, I think I was at 9 different state-based rural health meetings and also the NRHA meeting. And the conversations that we had really focus on the concept of ensuring that care can be equitably accessed, and we can do that through non-traditional ways. Because if we don't think about access to care differently than we always have, we won't be able to be financially sustainable or even operationally sustainable. And Jess, I saw your slide and I took a note of it. Journal of Cardiology published a paper in June of 2024, and I think we could probably use this study across any specialty. It doesn't have to be limited to cardiology, so I think you made a note about psychiatry, but specifically to cardiology, what these researchers identified was across 3,200 counties, 86% of rural US counties don't have a practicing cardiologist. That's a remarkable statistic, and we'll compare it in a second. But what's the impact of that? What's the impact of not having specialist access to care? Well, the impact is patients have to drive farther, right? We're talking an average round trip of 87 miles. And, as we, build different specialist programs, we just launched a remote dialysis program. When we talk about the public health impact of driving 87 miles, oftentimes that doesn't fall on the patient. That falls on the patient's spouse, and that falls on the patient's children, because ultimately the patient generally needs a driver for that distance. And the circle of impact that has, whether or not it's lost time at work to take off to drive a loved one, or frankly just the cost of driving alone, is really significant. And ultimately, what this study identified was a lack of practicing cardiologists in rural counties led to a 1-year shorter life expectancy for patients. That's a profound statistic when we think about the fact that, conversely, for those counties with cardiologists, those counties had over 24 cardiologists per county. So we're seeing a mismatch in supply and demand. And so access to care not being equal needs to be revisited, and we need to reinvent how we can make sure that access to care is available for rural hospitals. So I'll move to the next slide here. And we talked about resiliency, and I think resiliency is a great term. When Dr. Scurlock and I approach resiliency, we think about the model innovated by Partners in Health, which talks about the 5 S's. And the reason why about resiliency is truly defined that, in the manner of care delivery, whether or not there are situations that impact care delivery, whether they're small or large, any size, the goal is to be able to continue to offer that continuity of care. And through it, what we see is the unique combination of resiliency and high reliability. We really want to be able to deliver highly reliable care, because in a community setting, critical access hospitals want to be recognized by their patient population, by their staff for being consistent and for being reliable. And otherwise, those patients may look for care outside of that local critical access hospital. So what does resiliency, align to the 5 S's mean? Well, it means that we have to start with the staff, well-trained in sufficient quantity. Well-trained is a challenge, as Donna brought up, because oftentimes when we look at the critical access hospital, we may find that we have lesser tenured clinicians available. And when a lesser tenured clinician is on site at a critical access hospital, they may have less confidence in keeping higher acuity patients. And of course, as we do that, we see those patients being transferred. Secondly is stuff, right? Staff and stuff. Stuff is defined as ensuring that we have the tools and resources needed for care delivery. And as we attempt to maintain a higher level case mix index, maintain those patients instead of transferring them, stuff for us in a critical access community needs to be defined as technology. We need to look at different ways for inserting solutions to the care delivery challenges that otherwise are faced without the right specialist. And when we look at the aspects of resiliency, such as space and systems and social support, the 5S model of resiliency really speaks to how, as a critical access hospital, we can be sustainable. We can bring together the systems of care, which usually start with the executive sponsorship of new initiatives, which is a courageous move for a hospital administrator to seek out and focus on bringing new technology, new digital innovation to a hospital that otherwise may have not had those concepts. And when I look at some of the case studies we have generated through partners, the social support is actually bidirectional. In instances where we have launched programs around multi-specialty support or high acuity support or even nursing or telemetry, the social system, which includes the community, celebrates this. And we've seen those critical access hospitals share on their community channels, whether it's Facebook, whether it's press releases, even radio shows, about keeping care local. And really, to look around at the concept of resiliency in responding to workforce challenges, really there's nothing more than adopting that change and making your local community celebrate keeping care local. Now, when we think about the impact of transfers and what that means to the critical access hospital, we found a good resource from About Healthcare. This was previously known as Change. I would say every few years they periodically publish a patient leakage and keepage report. This report surveys roughly 150 hospital level C-suite, so CEO, et cetera, as well as directors of those health systems and hospitals. And what was so interesting to me when we think of transfers is the impact of a transfer is not isolated to the actual transfer of the patient one time. It really translates into a lifetime value of that patient being transferred and then receiving follow-up care from that alternate facility going forward. Mm-hmm. The key metrics and facts that I saw that I wanted to point out for this audience was one, when interviewed, hospital leaders saw patient leakage as one of the critical blocks from reaching their goals. So if we think about strategic planning, we're entering into 2025, right? And we're doing our 2025 strategic planning. How are we approaching patient leakage? What is our response? Are we able to introduce new services to make sure that patients do not bypass the local hospital? And we also see, as this report indicates, that outmigration really impacts that relationship with some of the competitors in the neighboring areas. Because once we remove that patient from our patient census, their follow-up care most likely is going to move to that other hospital system. Now, as we look through this, we talked about the statistics, and we see that 3 times more respondents said patient leakage was more important than managing changing payment models. Of course, we're interested in critical access hospitals to innovate our payment models to be able to pursue value-based care. However, if we're not creating the revenue stream from keeping patients, transitioning to value-based care is going to be very, very difficult.
Mm-hmm.
Now, we see the blueprint, we see the data, we see that it's a concern that patients leave our system. What I thought was remarkable is after all of that, 60% of those surveyed said they still didn't have a plan, right? How do we reduce patient leakage? Now, that's surprising. I think as we go into 2025, that's actionable, right? That's something that, you know, Huron's team can revisit with you, identify where and what types of patients are bypassed and not kept by your site. And, you know, leaving that impact of lifetime value, you know, lifetime value of keeping patients can be more than $600,000. That's a financial metric, but we just think about keeping care in the community. You know, as we travel to different states and we see how much pride, you know, surrounds the local community hospital and making sure that care can be local. That's also something that's based on word of mouth, being able to share, you know, where to receive care, and also being able to be seen as a trusted partner to the community and the community infrastructure. In our conversations, when we look at the critical access hospital and we look at the emergency department and how significant the emergency department is in solving the challenges of patient transfers and getting that patient started right on their journey through patient flow. And patient flow as a concept, I always think of it, you know, like ice skating, right? Patient flow is impacted most by friction. And friction creates waste, right? And so when we think about ice skating, it's a near frictionless environment. Our goal as hospital administrators is to try and attempt to create a minimum friction environment to optimize patient flow. And so we want to always have the right patient receiving the right care at the right time in the right place. Mm-hmm. Ultimately, we want that to be done by the right type of care provider. And so if we can optimize patient flow, we'll be able to minimize ED boarding and surge constraints that can happen, especially in seasons where we have an influx of influenza and flu cases blocking up our EDs. We also want to make sure that when delays in care coordination occur because maybe a patient presents and there isn't the right specialist available, we don't want that patient sitting in the ED waiting for care. Mm-hmm. And of course, you know, as we look at the inpatient arena, we want to make sure that a highly confident care team is available 24/7, you know, 7 days a week to be able to make sure that that patient receives the right care right in their community. And, you know, when we look at the patient journey, we want to spotlight a couple of those specific instances. So, you know, when we look at the admissions and transfer process, many times inefficient transfers lead to access and surge blocks. So now we have patients that are unable to stay in their community. They're spending too long in their ED, or potentially the local care team is trying to call hospitals that may have the right type of specialist available that can see this patient to be able to reroute them. Another impact on patient flow is a resource mismatch. This comes from not only a lack of staffing, but also potentially the lack of the right tenured staffing. And if there's lower confidence in being able to deliver that care locally, that local care team is going to recommend that that patient be transferred. We also want to focus on this concept of holistic interventions. And this is the ambition of patient-centric care, right? And we know through COVID that not only the patient matters, but the caregiver matters, and the well-being of the caregiver matters. And so when we think about care delivery, not only is it patient-centric, which means we want the patient to have a fantastic experience wherever they are, because when they have a fantastic experience, they're going to tell their friends that they had a fantastic experience. They're going to trust that their loved ones have a fantastic experience there. But also we want to make sure that the staff have a fantastic experience and ideally return joy to caregiving by supporting them, whether it's work-life balance. So in critical access hospital environments, we may see clinicians forced to work nights and weekends to spend less time with their family, which leads to burnout and dissatisfaction in their working conditions. So if we're ultimately able to provide solutions for low staff satisfaction and present them with the right caliber of collaboration and staff relationships through telehealth, that's a wonderful opportunity that we can create. And lastly, as we look at care delivery, standardizing care can return the efficiency that allows us to see not only sustainability, but also drive back patient quality, patient care quality, and ultimately organizational facility costs. If we reduce the variability in care through consistent care, through high reliability care, we really benefit as a hospital, but also as a community, a patient base, and a provider and caregiver base. So how can we do that through telehealth? We've talked about the fact that, we can't keep doing what we're doing because we don't have the right specialists where we need them. And agency labor costs and alternative costs are too prohibitive to make critical access care operations sustainable. Now, telehealth is a concept, a care at a distance concept that's been around quite a long time, but really it's one that through peer-reviewed evidence is starting to demonstrate true value, not only at large hospitals, but remarkably, critical access and rural hospitals are uniquely positioned to benefit from digital health. Examples that I'll go into with some models are: one, we've seen benefits in reducing overcrowding and unnecessary transfers. Imagine if that patient that comes to the ED can be triaged through telehealth and meet up with a cardiologist or a neurologist or a nephrologist that otherwise would not be available, and they'd be spending more time traveling outside of the local community. Teleconsultation and improved continuity focuses more on the patient flow optimization and really making consultations seamless. So supporting the bedside to the website connectivity to delay care and potentially reduce unnecessary transfers. There's an example of one hospital we met with. We're transferring one or two extra patients per day simply because they didn't have specialist access. If we're able to return those multi-specialty providers to the bedside in critical access hospitals through telehealth, we really deliver fantastic value for care continuity. Mm-hmm. Now, as we also measure and survey critical access hospitals, we see that staffing gaps create challenges not only in care delivery, but also the remaining staff satisfaction. And telehealth here can build a relationship, and it can be personal to make sure that those bedside caregivers are receiving recommendations and collaborations to be able to deliver better care and help reduce some of the challenges and impact of staffing gaps. And of course, when we look at scale for telehealth, telehealth at this point for critical access hospitals has literature that shows that we can standardize care delivery and really remove some of the variability that can result in reduced access to care, but also impact care quality. And we want to make sure that we can do that. And through it, really, the win-win-win is supporting the bedside care team, keeping higher acuity patients, helping caregivers on nights and weekends regain a balance in their personal lives, and of course also bring back some of those cases that we otherwise are losing to competitive hospitals. So, why trust us? Well, the real goal is to share literature. And the reason we share literature is because literature shows us that this has been done before. And as we approach telehealth and we elect to adopt new telehealth models, we can trust that somebody has done this before us. One example here that focuses on the emergency department was in Mississippi. And what we saw through this peer-reviewed study on tele-ED was we looked at 112 hospitals, or actually 14 hospitals, 112 hospital years, so multi-year study. And ultimately what we saw was tele-emergency was associated with a 31% lower annual ED cost. And that's really important when we look at the data behind retaining patients and improving the efficiency of emergency room operations. The second one focuses on inpatient higher acuity cases. And this is a study that came out of a community health system, 7-hospital health system in Massachusetts. And while that's larger than most rural networks, we do realize that critical access hospitals are steadily becoming integrated in and partnered with or affiliated with critical access hospital networks like this case. In this model, the hospital implemented a critical care or a high acuity telemedicine program. And by doing so, they were able to improve case volume by 21% and at scale, improve contribution margin by 600%. Well, that's a huge number. It's obviously a big system. But again, what we're trying to do is draw parallels to the case volume and the cost per case benefits that this hospital experienced through telehealth. And lastly, we're going to use an internal study that we executed. This is actually one that spotlights transfers, and we ran this study ourselves here at Equum. We compared a hospital that was actually transferring out several patients per day to a competitive hospital. And by doing so, they were losing revenue, and they were actually losing returning patient revenue. And so by implementing a high acuity telehealth program for the ED and for the inpatient, our teams were able to partner with this hospital and retain those patients, leading to multiple patients per day. And I think we're at over 200 patients per year in retention. And if we do the math on that, we're looking at about $10,000 per retained patient, really returning over $2 million to the health system per year, which is quite significant for a program. So I'm going to stop there. And I think what we've covered through this chat from Donna and Jess and then myself are the themes of sustainability, designing a roadmap for sustainable care delivery in a changing world. And while I have the questions up and we're looking for courageous questions, I've also provided some sample questions here that we've received from websites and webinars in the past. And I'll pose the question, and I hope that we get good access from you, Donna and Jess, on what your thoughts are. So a lot of this session, and I think the interest from CFOs, is on retaining patients locally. We talked a little bit about the financials. I talked a little bit about the social. Donna and Jess, maybe expand on that. Tell me a little bit more, and tell the audience a little bit more about, how does access to care lead to generating value for a critical access hospital?
Jess, I'll let you go first, then I'll jump in.
Yeah, so, I like the way that you think about it from a financial and a social perspective. I think first, the financial, if we think about it, loyal patients to an organization is going to lead towards predictable revenue, if you think about it from that perspective. From the social lens, when we go in and we assess an organization, a lot of them talk about the reputation that they have within the community. So if they can improve their reputation by providing services, that definitely improves that social component, right, and access. And I want to kind of lean into one example I can think of, particularly with an organization in Louisiana, and how they were able to expand their access to providers, access to services by leaning into telehealth, and they retrofitted a lot of their rooms with telehealth technology, and were able to they started off with doing a telespecialty program with cardiology, and then found that there was a need for virtual nursing, and because they wanted to fortify the nurses that they had, because they were unable to get high nurses with, let's just say, RNs and then specialty RNs from that sense. So they had a lot of LPNs on the floor. So by using virtual nursing, they were able to manage a lot of stuff that they did have. But then the way that also gave the hospital a higher reputation and be able to create that higher loyalty. So it was an interesting perspective that brought forward by utilizing telehealth technology. Donna, any thoughts from you?
Yeah, I wanted to give another example. This is such a fun example. One of our clients in Southern Illinois, as they were putting virtual nursing in and telehealth, the director of IT was so excited to share this experience with everybody that he took a telehealth cart to the golf course, and he parked himself at one of the holes, and he was able to show everybody who came by what they were doing and how they were doing telehealth and virtual care. And the response from the community was, we're so excited that our small community hospital is doing such great things with innovative technology. We never thought that we would see this in such a small area. And that really had a pride, like you said, Jessica, of, ownership and what a wonderful reputation we have. And, we're going to stay here. And wait, you're bringing providers here for us so that we don't have to go. So you're bringing them close to where we are. You're meeting us where we are. That was very impactful. And, there was part of the organization's strategy. They were trying to create stickiness with their clients, like you said. So keep them close to the brand loyalty and sticky. And what do you need? Because, one of the things that we find too is that patients are acting more like consumers every day. And so they really are looking for their healthcare organizations to empower them to manage their own care. And if you do that, along with, bringing the providers closer, virtual nursing, innovative technology, you can keep the services there. And as you said, Jessica, improve the financial status. Yeah.
Yeah, I love that. I love that story, Donna and Jess. And it almost leads me, when you think about that physician that did that, it almost leads to the question on technology about barriers. And I think, many times when we look at technology, we're concerned most about the concept of change and what does change mean for care delivery. And, the idea that innovation by itself can be disruptive. And innovation disruption is a big theme and a trend when we talk to organizations. And it sounds like that physician was a champion. And a lot of times, critical access hospitals and critical access hospital leaders need to lead as executive sponsors for new initiatives like adopting virtual care. And it's not something that is pushed down to the director of the ED or a sub-department initiative. If it's a strategy to solve for access to care, it comes from the CEO. It comes from the executive, right? What other barriers are you seeing?
Yeah, some of the other things that you hit on, one of the top is that you have to have that executive leadership. But then we're also seeing that there's a lack of provider and leadership adoption, a lack of resources to do this, and sometimes a lack of a strategy around how you can use this to move forward. A lot of our clients have developed the platforms for telehealth and virtual care, and they've put it in for one use case or maybe two. And so a lot of times, we've gone in to help them with their strategy and to enhance it, move it out, and they get really excited about other places they can go. Some of the other things that we see as barriers are around the data and analytics. Sometimes they're hard. It's hard to access the data and understand the data that you're getting. As well as, you've kind of hit on this with the change, it's the fear of the unknown. So what is this going to mean to us? How is this going to look? Oh my goodness, my job will change. What will that look like? So Jess, you've done some work around that area. I'm going to turn that over to you now.
Yeah, definitely the fear of the unknown. I think lack of change management to be established within an organization. I think about also digital and health literacy. That's a huge thing coming out of COVID. A lot of organizations know that it's a deficit, but don't have the time or the bandwidth to address it. I also think about resources. Hate to be redundant, but the workforce challenges are still an issue, and not having the capacity, because we go in and assess and we give this huge list of everybody that we want to talk to during a telehealth assessment, and it's the same people that show up for every single interview building out the telehealth program, and it's because the workforce constraints, right? And then having the infrastructure to be able to implement this, to making sure that there's the appropriate backbone in place to be able to support a program that will be worthwhile within an institution. The provider buy-in, that's another big one.
That's key. Yeah.
So I see a question about the slides and the recording. Cody was kind enough to mention that NRHA will be sending that out, so I'll be able to follow up with each of you with that recording. Donna and Jess, you just both brought up so many different ideas to talk about. One is telehealth for specific use case, right? What we sometimes call the burning challenge, right? What is my immediate need? And we've seen hospitals call and they say, look, our cardiologist just left, or our cardiologist decided to retire, or is planning to retire. We have a cardiologist shortage, or X and Y is a challenge. We no longer receive care because of this. That burning challenge leads to a tactical response, not a strategic response, which can lead to the conversation of telehealth. But let's build on that, because I think, telehealth to me is a tool, right? You still have to have an organizational strategy. How do you, from Huron, as you talk and coordinate, organizational planning, how does telehealth fit into organizational strategy for a critical access hospital?
That is such a great question, and that's one of the things we go. That's one of the things that we ask immediately as we walk in. So, what's your organizational strategy? What's your IT strategy? And do you have a telehealth strategy? Because it's really important to tie those all together in order to have success. So we work on that, and then as we start to, sometimes we even do visioning sessions with our clients to get a better understanding of what those things are. And it's during those visioning sessions that we start to identify areas for potential use cases. So Jessica has been really successful with her clients moving into areas such as school-based telehealth, prisons. For one of our clients, there was such a need to access the prison population to keep the provider from having to go and spend the time back and forth. By automating that with telehealth and virtual care, it just saves so much time. And the patients are able to get much better care because she can see them more often. And, with some of the things too, we'll look at what's going on in your neighborhood? So have you done a marketing assessment for what chronic illnesses, which Jess talked about earlier, are you trying to improve? You know, one of our clients had a very severe issue with diabetes, management of diabetes in her community. And so through telehealth and some remote patient monitoring, she was able to reduce her numbers, and it's just amazing. She's very proud of that, and the patients are really excited about it because they're part of their own care, and you know, they're managing it. So that helps keep the readmissions down too. So Jess, what else from your standpoint?
I think it's having the right people at the table.
Yes.
Also, you know, one, do you have a strategy? If you don't have a strategy, let's talk strategy, right?
Yeah.
If you're embedding telehealth priorities into your strategic plan, that's fine. But let's talk about what the strategies need to be, and let's use data to drive those strategies, and then make sure the right stakeholders are at the table to map that out. Make sure that they're aligning what the community needs are and what's the needs of your within your organization. And make sure that they're driving to the end goal of what's going to be most beneficial to your organization. Because what do we want to occur? We need adoption. And if you're not selecting strategic priorities that are going to benefit your end users, one being your nursing staff and two being your providers, then what's the purpose, right? Because one, your providers are not going to order it, and two, your nurses are not going to utilize it. So you got to make sure that they're engaged and they're going to be part of the process to adopt it and the end goal there. But I hate to reiterate that also the data component of it, going through a strategic planning session with large institutions and small, if you have the data to kind of drive how you're planning, you're drafting that strategic plan or even goals, it's very important to understand current state to move to future state.
You know, one of the things, Karsten, that as Jessica and I have done these strategic planning sessions with our clients that we've been surprised to find is around the IT infrastructure. So Jessica mentioned that a little while ago, but as we get into the strategy and the different use cases, we talk to the clients and help them understand if they have the technology, the infrastructure, and the IT staff to move forward with what they're looking to do. And so sometimes they don't. So that's why I said when we look at strategy, we like to look at organizational, telehealth, virtual, and then technology, because you really need to make sure that you have the infrastructure and the resources set up to support where you want to go.
That's terrific. And I think you were able to build on so many interesting points. You know, when we look at barriers, one of the ones always is investment, right? Because there's a cost, and you're going to see the cost before you see the ROI. I think, Jess, your point about data is vital because there's enough, you know, implementing telehealth requires the data so we can show the ROI. So it's absolutely critical. But again, especially over the next couple months, USDA, CMS, other organizations are bringing grant funding, sustainable funding, not only for infrastructure, but for technology. And the reason is to encourage the application of telehealth. So, you know, if the barriers are cost, focus on that. But I would almost expect that the ROI that we're trying to, you know, convey comes from the data. So setting up a telehealth program doesn't start with a telehealth program. It starts with what are the variables that we want to, you know, test and maintain so we can actually show the value. For the audience, this session has focused on resiliency. It's focused on generating an ROI, or at least an organizational interest in integrating virtual care to combat workforce challenges. Donna, Jessica, thank you. Obviously, Corey's leadership and input has helped me convey the message. If we're going to end on time, which is the goal, we've got 2 minutes, can I challenge each of you with a final thought, a final call to action for our participants?
My favorite is, and you heard it as I was talking through my slides. It's time to really think, or plan, I should say, plan, think, and do differently. So you can't, did I take yours, Jess? You can't maintain the status quo. You really need to be thinking about this differently and be ready to make the bold moves. Jess?
You just said 2 of them. You took.
Oh, I'm sorry.
No, you know, I think it's having the conversation. It's not being afraid to have the conversation about virtual care and telehealth, and not being afraid to change. You know, we may have virtual care now, but you still have to continue to change it and adopt, you know, optimize it and continue to grow with it.
Well, and I'm a marketing guy, so I always just come up with images, and the image which I scratched together after a presentation that I listened to a few weeks ago is, you know, you think about that sign at the pool growing up that said walk, don't run. Well, in critical access hospital landscape today, I would change that sign to say run, don't walk. This isn't something which we need to do slowly. This is something that we can do to change outcomes today. So this session was, you know, put together by NRHA. We're very grateful and proud participants from Huron and Equum. We will share the slides and the recording. Thank you very much for your participation and interest.
Thank you, everybody. Have a good day.
Thank you all. Everyone be safe.